This is Dr. Richard Herman. I'm a diplomate of the American Board of Endodontics. I'm going to talk about sealers on behalf of Real World Endo. When we talk about sealers, we first ask ourselves, do we really need sealers in endodontics? And the answer is absolutely yes. We are using sealers as they are necessary to obtain an impermeable, fluid-tight seal, both apically and coronally. There was a paper by Swanson Madison in 1987 that confirmed that apical and coronal seal are significant factors in the prognosis of root canal therapy. So when we talk about sealers, we want to talk about some of the requirements of an ideal root canal sealer. And it hasn't changed much from when Grossman introduced the requirements in 1978. One, he said it had to be easily introduced into the canal, seal the canal laterally as well as apically, not shrink after being inserted. It should be impervious to moisture. It should be bacteriostatic or at least not encourage bacterial growth. It should be radiopaque, should not stain tooth structure, does not irritate periapical tissue. It should be sterile or quickly and easily sterilized before insertion, and it should be easily removed from the root canal if necessary. So let's talk about the different types of sealers that have been around for many, many years. First, we talk about zinc oxide and eugenol sealers. The three most popular were tubeless seal, wax sealer, and Grossman's. So the advantages were, one, they had slow set time, except a little bit, tubeless seal was a little bit faster. It resorbs if extruded. It's soluble when you retreat, and it's antimicrobial. Some of the disadvantages of the zinc oxide eugenol sealer: it does not bond well to dentin or gutta percha, some shrinkage upon setting, toxicity when it is fresh, and it does stain. The second one sealer that I'd like to talk about is calcium hydroxide, and the two most popular are Sealapex and Apexit. So again, some of the advantages of calcium hydroxide sealers: it expands while setting, especially Sealapex, sets in dry or humid environment, and it may be osteoconductive as well as osteogenic. It may cause chronic inflammation in periodontal ligament, which is a disadvantage. Other disadvantages is it may dissolve periapically, compromising the seal, and it takes a long time to set, sometimes up to 3 weeks. It has moderate antimicrobial effect. Then there are the resin-based sealers. These have been very, very popular over many years. Some of the most ones used were AH26, AH+, and Thermoseal. Advantages: tissue compatible after 72 hours. It is radiopaque. It has a flow rate, and it bonds to dentin and gutta percha. Disadvantages of resin-based sealers: one, it stains. A long set time can go up to 8 or 36 hours. Leakage upon shrinkage. If you over-obturate, it is hard to see the resorption of the resin component and has moderate antimicrobial effects. Next one is glass ionomer-based sealers. Most used one is Keytac Endo. Advantages is it has good adhesion to the canal walls, has poor adhesion to the final obturating material. It's difficult to remove if retreatment becomes necessary. That's a big disadvantage. And it sets very rapidly and has short-term antimicrobial activity. A big disadvantage, it really becomes almost impossible to remove. One of the last ones I'm going to discuss is solvent-based sealers, mostly gutta percha, chloropercha, I'm sorry. It was popularized by Johnson and Callahan in 1927. It's a mixture of gutta percha and chloropercha, but it has extreme shrinkage. Not used that much anymore. So then we get to the newest type of sealers in bioceramics. So let me say this. Back in the 70s, one of the icons in endodontics was Herb Schuller. He recognized the disadvantages of sealer. He knew there was a problem with the difference between the dentin and the gutta percha. They shrunk a lot and they weren't dimensionally stable. So in bioceramics, we talk about MTA was the first bioceramic material used clinically in endodontics. Other than MTA, literature on bioceramics and endodontics was scarce until 7 years ago. And since the introduction of MTA, bioceramic cements became a material of choice in the treatment of open apices, resorptions, perforations, pulp capping, retrograde fillings, high-quality sealing, apexification, and in regenerative endodontics. So when I talk about MTA, that's known as mineral trioxide aggregate. It's discovered by Mahmoud Turbanamajid from Loma Linda University in 1993. It has been extensively researched. It has a high pH. It's biocompatible and bioactive when set. Excellent seal, and it comes in a gray and white formulation. Recent bioceramics, in 2009, endosequence BC sealer and root repair material came into being. And that was introduced at the AA meeting again in 2009. I'm a big, huge advocate of bioceramics, especially the endosequence BC sealer and root repair material. Other bioceramics that you might hear about are biodentin, which is a dentin replacement. You might hear about MTA Filapex. But the bottom line is the application of bioceramic technology changed surgical and non-surgical endodontic treatment. So there's a company known as Innovative Bioceramics Incorporated. It's been around for a long time, and their whole mantra is to advance bioceramics for the benefit of orthopedics and dentistry. As a side note, if you know that most of all your hip replacements and knee replacements are covered with bioceramics. And last year, while I was up in Boston and broke my hip, I had some pins placed, and they are covered with bioceramics. The orthopedic surgeon had told me that. So when you talk about bioceramics, I love to talk about the bioceramics that was introduced by Brasler. We have an endosequence BC sealer. We have an endosequence root repair material, which is a paste and a putty. It comes in 4 formulations. One, it comes in a syringe, which is great because it's pre-mixed. It's easily introduced into the canal. And then we have one that's called the root repair material. It comes in a paste. Then it comes in a jar as well. And it comes in another syringe, which is called fast set. The only difference between all of these is the seal comes with 2 microns, which is easily flowable. And the others come anywhere between 50 microns and 200 microns. But they are fabulous, fabulous materials, all new and material science. The BC sealer is the only premixed bioceramic sealer available. It's a calcium silicate, calcium phosphate preparation. It's highly hydrophilic. Natural moisture in canal is advantageous. It's not only advantageous, it's necessary for the material to set. It's antibacterial, it's osteogenic, biocompatible, and it has a pH above 12. When we use the sealer in the canal, we use an obturation technique called hydraulic condensation, where gutta-percha becomes the primary delivery device. It can be used with regular gutta-percha, or it can be used with BC impregnated gutta-percha. I love to use the BC impregnated gutta-percha because what happens is it bonds to dentin, it bonds to the gutta-percha, and we get a monoblock. So here's a picture that I like to show. This is some literature was produced by Trope and Debillion. And what it does is they're cutting the apices of the tooth and at different levels. One's a 0.5 millimeter, one's 1.5 millimeters, one 3 millimeters. And if you could see the picture, you could see there are no voids at all in the bioceramic cement. It's an amazing, amazing material. This has been shown many times. We have a great video that we're not going to show today because it's too long, but Ali did it when he had to extract a tooth that had root canal therapy because of a fracture, and he unedited it and showed from apex all the way coronally, no absolute any voids. So hydraulic condensation technique sealer resulting in lateral canal puffs. Here's a case. This is Debillion's case, and I like to show it because he uses a protocol with instrumentation, but he uses the bioceramic sealer, and you can see how nice it comes with the puff. This is a case that I did. It's a 3-canal bicuspid, and you can see that we were able to obturate the canal just using sealer and gutta-percha. The literature shows that we should try to get to a 3004 in order to get our irrigation protocol to work, so we can get all the cleaning of the root canal to the best of our ability, which works very, very well. In the previous presentation, I showed you ultrasonic technique to do it. Another case that I did was this one, and this is a funky kind of X-ray radiograph, and here's the post-op. And you could see that on the distal root, I wasn't able to instrument all that, but when you're able to use hydraulic condensation with the bioceramic sealer, you can see how it flows and how we get the lateral accessory canals, anastomosis, and so on. So then there's another thing that came out. It's beside the sealer, it's a root repair material. I have to talk about this because I'm such a big advocate and have such a great passion for the EndoSequence bioceramic material. The bioceramic material delivered as a premixed moldable paste or in a syringe. It has a working time in 30 minutes, sets in about 4 hours. It's extremely hydrophilic, presence of moisture to harden, which I mentioned before, you need that. And it's biocompatible, osteogenic, and antibacterial. Here's a case by one of our faculty members at Real World Endo. We like to call it one of our famous cases. It's by Art Lane. He had seen this patient, and you could see that the post perforates the tooth. He told the patient at that time that he had to extract the tooth. The patient would not hear about it. So he removed the post, and here's a picture of the post being removed. He presented with bioceramic putty, and you can see that as a post-op. And here's a 2-month recall, a 7-month recall, an 11-month recall, and here's a 22-month recall. And you could see the healing properties of this amazing material. So then we have the root end filling material for our retrogrades. Now I could tell you that because of the surgical operating microscope, because of ultrasonics, and because of material science and bioceramics, that our surgical success has gone up from 50 to 59% to 70%, which was reported in the literature many years ago, all the way to 93 to 96%. Shimbori in 2015 showed there was a 92% success rate. It's a viable alternative to MTA as a root end filling material. The EndoSequence bioceramic root material is suitable for root end filling material for endodontic surgery. So in 2015, Chen did a study where he used the MTA, gray MTA, EndoSequence root repair putty. Root repair material has superior healing in CBCT and micro CT imaging. Both materials exhibited superior sealing ability. There was a 92.6% complete healing with root repair material and 75% complete healing with MTA. Again, in 2015, he stated significantly greater root end surface was more covered with cementum-like tissue, PDM-like tissue, and bone in root repair material group. Both materials stimulated progenitide cells and bone, and both had minimal or no inflammatory response for either material. There are many, many other articles that show the greatness of bioceramic root repair material. Like I can mention a bunch of them, but one of the real ones was Kim and Rubenstein. And then in conclusion, what I like to say about bioceramics and tell you what it's all about: it does not shrink. It's chemically stable within the biological environment. Little inflammatory response, forms hydroxyapatite. It bonds to dentin and the gutta-percha if you use the impregnated gutta-percha. It enhances biocompatibility, increases the strength of root following obturation, has a high pH level, and has excellent handling materials. So I presented to you sealers that have been used over many, many years. And again, to state Herb Schuller, everything was not dimensionally stable, and that's how he developed the warm vertical condensation technique. So what he wanted to do was push the gutta-percha laterally and apically. With the bioceramic material, when we're doing sealing and obturation, we are pushing the sealer apically and laterally, and we are getting a beautiful, beautiful result. So that concludes my short presentation today. Thank you very much.